Good morning, Tony Appleberg Parks, your CDI and coding educator, risk adjustment educator here, and I'd like to welcome you back to the channel. Um, Today we're going to take a close structural look at something that every coder and CDI specialist touches almost every day, the physician query. It depends on the area of coding you're in, but yes. So specifically, we're going to dissect the anatomy of a compliant query piece by piece, so you walk away able to build one and spot one that's broken every single time. Okay, so let's get started by looking at the stakes here. A non-compliant query. This isn't just a paperwork problem. Leading queries can be viewed as directing a diagnosis or leading a diagnosis rather than clarifying one, which puts that diagnosis and the revenue tied to it at risk if there's an audit. So in the outpatient risk adjustment world, we see that risk show up directly in RADV audits, where CMS validates whether every HCC submitted for payment is actually supported by compliant documentation. And a query that leads the provider to an answer instead of asking them to determine one, that can undermine the support. So it's not only, that we need to get it right, but this is how we protect our organization's revenue integrity and also our own professional credibility. So it's very, very early where I am. I hope I'm not sounding too much like a frog. So I appreciate your patience there. So let's talk about what exactly a query is. At its core, a query is a communication tool. It can be a written or verbal question posed to a provider to clarify some documentation that's incomplete, or it may be conflicting or ambiguous. So it's not a tool for telling the provider what to write. That's what we have to remember. It's not a checklist that you fill out for them. It's a kind of an open-ended, usually not always open-ended, but best ones are open-ended questions. And how that question is built determines whether it's compliant or not. So you'll be seeing some examples of those more compliant or non-compliant queries. So the industry standard for query compliance comes from a joint practice brief by ACTIS and AHIMA. So that's the Association of Clinical Documentation Integrity Specialists and the American Health Information Management Association. The current official version is the 2022 update with an addendum added in 2023 addressing denial trends. So one thing we want to look at that's pretty timely as of this recording, ACTIS and AHIMA do have a 2026 update in progress. A draft went out for public comment earlier this year, and the final version is expected soon, but it's not published yet. So we're watching for that. So, but everything we covered today reflects the current official 2022 standard. Okay, so by the time you see this, it could be different. So always do your homework. So I will try to make sure to do a dedicated video the moment the 2026 version is finalized. Like I said, it's early. I have a frog in my throat. I got to keep that warm coffee coming, right? What time is it where you are? Okay. Now here's the single most important concept in this entire training, this video. The difference between a compliant query and a leading query, okay? So a compliant query presents clinical indicators and asks the provider to draw their own conclusion. A leading query suggests the diagnosis and the query wants to, whatever you as the querier wants to see documented. So the difference here would be something like which diagnosis is linked to this medication or something versus is this medication treating diabetes? And you're trying to capture a diabetes code, right? Or that in your mind, you know that's the diagnosis that you think it is and you're looking for, but the provider has to say that. You can't say that. So, so it's a fine line between them, and it's not about intent, it's about structure. So a well-meaning query, you know, can still be leading if it's built wrong. So that's why we're going to break down the anatomy of these piece by piece. Okay, so every compliant query starts with clinical indicators. So the objective of that is chart documented evidence that justifies asking that question in the first place. So it could be an abnormal lab value, a medication, an imaging finding, or maybe a symptom that the provider already documented. So the rule is quite simple. If you can't point to something already in the record that justifies and supports that query, you probably don't have the grounds to ask it yet. So here's the actual question. You know, as I mentioned earlier, I prefer the open-ended questions, and they should be open-ended whenever possible, asking the provider to clarify, specify, or further define a condition, rather than asking them to confirm a specific diagnosis that you've already named. If there are maybe a couple listed diagnoses that are conflicting, then in that case you may create a query where they choose one or the other. But in that case, you probably have two different providers that have made a diagnosis, and you're just trying to determine what the current provider wants to capture. So compare, clarify the type and etiology of the patient's anemia to this one. The patient's anemia is due to chronic kidney disease, correct? Okay, so I don't know if I said that very well. So I just want you to compare these two. Please clarify the type and etiology of the patient's anemia. That's number one. And the patient's anemia is due to chronic kidney disease, correct? That question is number two. Okay, so what do we have? The first one invites clinical judgment. The second one is just asking for a rubber stamp. Okay, so which one's the better? So multiple choice format is an option, and if you're using a multiple choice format, every option needs to be clinically reasonable and supported by something in the record, not just the one diagnosis that you're hoping for or you think is correct, surrounded by three that are obviously wrong options. That's not going to work. It's not a test question. Okay, and per the guidelines, providing reference definitions or clinical criteria alongside the choices, that is allowed, but that information can't highlight or point toward a desired answer. That's the key thing about that. So for your query to be compliant, it should reference exactly where the clinical indicators are in the chart. So you should be pointing to a specific note, date, or location, like, for example, H&P dated 3/14. So this does a couple things. It lets the provider verify your reasoning very quickly, and it creates an audit trail showing that your query was grounded in real documentation and not an assumption. So every query needs to have an out. Providers have to always have the option to say the diagnosis in question can't be clinically determined from the available information. And you may only get one shot, so make sure that you're finding that appropriate data to help that provider make that determination. We don't want to, we really don't want, we want them to give us some diagnosis, not can't be determined from the available information. That's not getting us anywhere, right? So that's why it's so important for us to find the validating information and present that to the providers. Having that out, though, is a required component of compliant query design. So it's not just a nice to have. Without that, you're removing the provider's ability to disagree, and that in itself makes the query leading. Okay, so let's look at this example. This is a query that looks reasonable on the surface. The patient has elevated creatinine and is on dialysis. So please confirm diagnosis of end-stage renal disease. So let me read that again. Patient has elevated creatinine and is on dialysis. Please confirm diagnosis of end-stage renal disease. That's the query. So notice what's missing here. There's no open question, no alternative answer choices, no unable to determine option. It tells the provider the answer and is asking them to sign off on it. Okay, that's non-compliant. Okay, so here's the same clinical scenario, but this one's rebuilt compliantly. So here's our query. Clinical indicators note creatinine of 6.8, lab of 3.2, and dialysis 3 times weekly, and that's from the nursing note on 3.2. Please clarify the specificity of the patient's renal disease. A, chronic kidney disease stage 5, B, end-stage renal disease, C, acute kidney injury superimposed on CKD, or D, other, please specify, or E, unable to determine from available clinical information. So this is how you would do a multiple choice, but the same clinical scenario as the first example, but this is a completely different structure because now the provider is doing the clinical thinking and not just confirming yours. And they have an out. They may not agree with any of those options, so that's important. All right, so let's talk about a few traps that show up again and again in real audits. So the first one is embedding the desired diagnosis directly in the clinical indicators section. Can't do that. Second, bolding, underlining, or highlighting one answer choice. Okay, I don't know what that is, but we can't do that either. And the third one, offering only one clinically plausible option among several implausible ones. Do you think that's leading? Of course it is, right? And then the fourth one, framing yes or no questions in a way that only leaves room for one reasonable answer. That's why having multiple choice with also an out, kind of a none of the above, is important. And that's why even better is using an open-ended question. Just, tell them what you see. Like, I see this medication that I know treats a specific disease, but I want you to tell me what disease you're treating with this medication. So, what is the diagnostic indicator for the metformin? What are you using the metformin to treat? Something open-ended like that it would be a very good query. So any of these non-compliant things that I've shared with you, can turn an otherwise well-intentioned query into a non-compliant one. So any of these four, just really be careful there. Now, queries don't have to be written to count. I personally like them to be. I like that paper trail. But verbal queries are permitted and do happen often, especially in fast-paced outpatient settings. Doctor's handy, you need a quick answer, but a verbal query still does have to meet every compliance standard we just covered, and it needs to be documented that way, showing who asked, what was asked, and what the provider's exact response was. So ideally we want it to be in the provider's own words in the medical record. So if it's not documented, it didn't happen as far as an auditor is concerned, right? It applies to all of us, not just the docs. And while we're on the topic of documentation, query retention does matter. Your organization should have a policy that specifies how long queries themselves are retained, and that should be separate from the medical record, and whether the query is considered part of the legal health record. Just tracking queries, I think, is a good record, and then having, some EMRs give you the ability to query within the record. I use Athena the most, and that is something that we can do in there. But there should be an outside record that just shows that compliance. So, but it should be spelled out in a written query policy for your organization, and all of your CDI and coding professionals should know where the policy lives and what it says. So do your own training on this. Now, can you query the same encounter more than once? Well, yes, you can. But each additional query needs its own independent clinical justification. So repeatedly querying the same provider on the same encounter until you get the answer you want, that's a compliance red flag. So if you need to do more than one query, that's fine, but don't keep querying the same question trying to get a different answer. Sometimes this can be seen as query fatigue or query harassment in audit findings, and so it's important that each query can stand on its own clinical merit. Now, because so many of you work in outpatient and ambulatory settings, especially for people that follow this channel, because that's where risk adjustment lives, a few things do shift compared to inpatient. Turnaround time is often faster on these, and you might have only one visit, one note, and one shot to clarify before that claim goes out. So there's also more of a reliance on the problem list documentation, and it's less reliance on discharge summaries like we see in inpatient. So the compliance bar isn't moving, but the workflow around it, that's what kind of changes depending on whether we're inpatient or outpatient. Now, if you really want to know what auditors actually flag, I can tell you it's rarely subtle. It's missing clinical indicators, answer choices that are obviously stacked, no unable to determine option, verbal queries that don't have a documentation trail, and then multiple queries that are chasing the same diagnosis without any new clinical justification. So if you build every query with the 5 anatomical pieces that we covered today, then you're already ahead of the game, or ahead of, the common things that show up in denial letters. Okay, so that's pretty much a wrap, but I just, before we close, I want to give you a little preview of what's coming up. With the 2026 draft update, again, that's not yet final, but it will expand on a few areas, clearer rules around what counts as a non-compliant multiple query, guidance on querying based on prior encounters, and more notably, a compliance framework for technology-generated queries as we become more technology-driven, right? So that last one covers prompts, alerts, and nudges generated by AI-assisted documentation tools. And this is increasingly common in EHRs. Whether you feel it's good or bad, it's there, it's coming, and it's important that we have these checks and balances. So the core anatomy of a query that we covered today isn't going anywhere, but I'm going to, in the future, bring you a full breakdown once the final version is published also. So if you want to make sure you catch that when it's released, please make sure you subscribe to the channel. And of course, I always appreciate your likes and shares and things like that. It helps get this information out to more coders and providers and office managers and people that I hope it's helpful for. So just to do a quick recap before we bring it home, remember a compliant query has 5 parts: clinical indicators grounded in the chart, an open clinical question that's balanced and reasonable answer choices, a specific chart reference, and of course an unable to determine option. So if we miss any one of those, we have built something that an auditor can challenge. So if we build it with all 5 every time, it's a query that is probably going to hold up. Okay, just a few resources if you want to dig further. And I want to thank you for your time and attention today, and please reach out if there's anything I can help you with. So once again, if this helped to clarify how to build or elevate a query, evaluate a query, I hope you'll give the video a like and a subscribe so that you can get more CDI and coding education. And if you need any help with outpatient CDI, HCC, risk adjustment auditing, or your provider education, please also visit helpfordocs.com. As you see it written on the screen, help number 4 in docs.com. And I'll see you in the next one. Have a great day.